A second folder has 3 sets of templates. So the CAP templates, the ICCR templates, and a proposed abbreviated template for the particular disease presentations and considering some of the challenges that some of your practice situations might have. And then a third folder has the NCCN Africa documents, as well as the recommended evidence to decision frameworks that are now recommended to make decisions. And basically, those frameworks include, in addition to sort of evidence, right? We all sort of try to make evidence-based decisions, but evidence-based decisions are not always implementable because of lack of resources, either structural resources, human resources, or the particular cultural environment in which they're being used. And so the recent GRADE evidence to decision frameworks include accessibility and feasibility assessments to determine whether a particular evidence-based decision will actually benefit from implementation in the local setting that there are. So there are a series of questions. I've organized it into an Excel file with my hypothetical answers from where I'm sitting, but we need to have a discussion with the participants from Africa contributing to let us, to decide whether, well, is this feasible? Isn't this feasible? Does it apply to this setting or not? Do we have access to this? Do we not have access to that? So for instance, for endometrial cancer, FIGO 2023 recommends trying to do molecular subtyping. From my understanding, that is not feasible in most of your settings. And so including that into a standardized reporting format is basically going to be that every case says not applicable or something like that. And it would probably be better to remove that from the reporting format. One of the reasons that I came up with what the template that I've attached there is that it's a one-page template. Again, you guys are going to have to inform, maybe it's too simplistic and it's a royal waste of time. The other thing, for instance, I put in, in the cervical carcinoma protocol is that in most of the countries with more advanced presentation of cervical cancer, neoadjuvant chemotherapy or neoadjuvant chemoradiation is the standard recommendation, whereas in the US, it's really, because most of our cases present earlier, it's direct surgery. I don't know the last time that I had to assess whether there was a chemotherapy-associated response in a cervical cancer. That was during residency that I did that. So that's sort of the overview of the project. My hope is that we can all meet next week again. I don't know, the mentors don't necessarily need to be there. It's up to you whether you attend or not, but I think we need to start moving forwards stepwise through each of these things. I think Aisha had a question about, I used the word a fictional case report or something like that. So I think, one of the problems with the standardized reporting that has been introduced in the Western world is that pathologists put this together. So there are a lot of elements in there because we thought they were important, but it has created a lot of extra work for pathologists, and the clinicians are not entirely happy with the output because there's a lot of little bits of information and the display of the information. So I thought that one thing that we need to do is, you know, we create what is your typical case of cervical carcinoma, like, how big was the tumor, what did you see, whatever. And then we format it in all three different formats and then present that to our IGCS clinical fellows who want to participate in the project and ask them to rate which report is most usable to them in their context. I do have a bias here. My bias is that I don't believe that multitasking has to be very, very thoughtful and easy to do. We have gone towards a model where the pathology report serves as a data collection instrument, as a communication instrument to the clinicians, as a communication instrument to patients. And that has created a certain amount of chaos because, I can't, one of our very high severity errors that we have experienced, and it's always 2 or 3 pretty much consistently every year, is that the clinician has missed a special stain result. Like, the HER2 was reported in the synoptic format as 2+ equivocal, and then it turned positive on FISH, and that was overlooked somehow, and the patient never got the treatment that they needed. And part of it is because of where it attaches in the report. So we're working on that. So I think these are lessons learned from our experimentation with standardized reporting. And so I think it would be good for us to get clinician input earlier rather than based on errors or failures that we have after the report is released. Plus, we are working under the umbrella of IGCS, and so that is a specific request made from them. So I think that's about the project. We'll pick up again next week, same time. If that time works for everybody, Abby will reach out and confirm that most people can attend at that time. The other request, so what I did is, and I'm hoping that this is going to work, as you can see, I'm still in my old office, but I'm very discombobulated because half of my things have been moved and half of them haven't. So my IT folks were very generous and reconnected my camera to the computer this morning. So hopefully I can share. And let's see, share. No, not it. Louis, you would have to, I think you have to give me privileges. So a request was made, and I don't remember, I think it was 2 sessions ago. One, I forget, I don't know. I think it was Aisha, but maybe it was somebody else had presented a mucinous ovarian case. And then we had a discussion and people wanted to, we thought we would attempt looking at slides together to cover the whole gamut of cases. So I pulled out what I had, and so I'm going to share my screen here and we'll do this session that way, and then we can decide. So let's see here. So the first few cases I think are straightforward. That's just to set the stage, but I wanted to it's always good to start at the beginning. So as you can see, this is a mucinous lesion. The cute thing about this case is that it also has this sitting next to it, maybe better seen on lower magnification. People should jump in and make their diagnoses if they want to or comment on it, but this is just a mucinous cystadenoma arising in a Brenner tumor. You can also have borderline tumors arising with Brenner tumors. The second tumor that mucinous tumors arise with often are teratomas. So here you have a teratoma, and here's a mucinous tumor arising in a teratoma. This more sections showed that it was a borderline mucinous tumor. And as you can see, this type is intestinal. So if we were to do immunohistochemical stains on this tumor, actually we did do immunohistochemical stains on this, and this mucinous tumor was CDX2, CK20 positive and CK7 negative because it's arising in a teratoma, probably from gastrointestinal tissue in a teratoma. I also want to show you this case was very, very interesting. This is a very young patient, and the patient actually presented with what they thought was a drug overdose, side effects of a drug overdose. She was psychologically disoriented and she was very sick when she presented, but the patient had actually an ovarian mass, and this is an NMDA type teratoma. So a subset of especially young women can get that have NMDA antibody. It creates an autoimmune sort of response, and it's related to the teratoma. And once the teratoma is removed, the patient actually shows remarkable improvement. And one of the findings that you can see in an NMDA type teratoma is this infiltration of the tumor with lymphocytes. Oftentimes the lymphocytes are actually associated with brain tissue elements that are in the teratoma, but they can also be seen in patients. That inflammation can also be seen in teratomas that don't have brain tissue, and the patients present the same way. You can actually go on YouTube and see the behaviors of these patients. They have a very characteristic body movement, chorioathetosis, and they actually have this weird sort of chewing demeanor that they have that often points the clinicians to the right diagnosis. Of course, the clinicians often don't tell us that they already know the diagnosis, which is annoying, but every so often you catch it before they do. So this is arising in a teratoma, but also next door, as you can see, there are thyroid components in this teratoma. So I wanted to make a mention of that. So mucinous tumors also have a higher, the other two tumors that they can coexist with is carcinoid tumor and heterologous Sertoli Leydig cell tumor can also have a mucinous tumor. So whenever you get a mucinous tumor, you really want to make sure that you look for any existing different components so that you can identify whether the tumor is, whether there's a mixture of tumors. And the two tumors that would be really important to identify is carcinoid, because carcinoids are potentially malignant tumors, and Sertoli Leydig cell tumors, because that's also potentially is a malignant tumor if it's a higher grade. So you don't want to miss those, because those are the ones that will direct the prognosis for the patient. I guess if you miss a teratoma or a Brenner tumor, it's not the end of the world.
Can I just make a quick comment?
Yes, please.
Yeah, no, that's an excellent point. I had a case that came to consultation as the initial diagnosis was a mucinous tumor. And actually, so with additional sampling, we found that indeed it was a Sertoli Leydig cell tumor. And so sometimes the mucinous component in a Sertoli Leydig cell tumor can be pretty dominant. So it can really fool you. So that's an excellent point, is just to make sure that you're not dealing with another tumor, which be exactly like you said, you don't want to miss a Sertoli Leydig cell. So I just wanted to put that in there because that can happen.
Yeah, and I think it also happens more commonly with mucinous tumors because mucinous tumors actually grow to be very large. So the largest tumors reported in the ovary are mucinous cystadenoma. You know, they've been 300 pounds and stuff like that. So, and so for that reason, also sort of the other component can be hidden. So this is a tumor in which the gross examination is very, very important, and making sure that the different types of areas in the tumors are adequately sampled is very important for mucinous tumors. Wait, did I go over this case already? So this is just I think more or less a regular, everybody would call it a mucinous cystadenoma. It isn't complex, but it is beginning to show sort of goblet cell and fovea. But this is definitely a gastrointestinal type tumor. We'll get back to that in a minute. So now the question is, how would you qualify this tumor? And let's just stay with this particular piece. Sorry, wrong direction. No, this is my lowest magnification, sorry. So I don't know, any thoughts on how you guys would classify this tumor?
Yeah, borderline, mucinous borderline tumor.
Aisha, I'm sorry, could you speak up a little bit? I can't hear you too well.
Okay, probably mucinous borderline tumor.
Okay, is everybody on the same page on this one? So I'm going to,
Can we see these solid looking areas?
I'm sure.
Yeah.
So the solid looking areas have two things going on. Most of it is ovarian stroma, but I don't know if you can see, there are some clusters of luteinized cells in here, but you can see that in almost any ovarian tumor. It's not projecting as well, but there are little nests of luteinized stromal cells. But the stroma is overall unremarkable. It's fibrotic, usual ovarian type stroma. So I guess, you know,
This be adenofibroma?
it's a fair point. I mean, I don't think the fibromatous component in this tumor is enough, but I think you're on the right point that an adenofibroma is a benign tumor, whereas a borderline tumor is a borderline tumor. So I think the question here is, would you call it borderline or just cystadenoma? Or mucinous adenofibroma. And I think, so I can tell you that maybe even as much as 5 years ago, I would have called this a borderline tumor. But today I would probably report this as a cystadenoma. I think this is an area of disagreement amongst pathologists. So the new WHO book says that you need to see some level of true epithelial proliferation. You know, it's difficult to know what that means because technically speaking, if there is a lot of cysts, that's an indication that there's a lot of epithelium, but I don't see good complexity to this epithelium. You know, there's a few papillae like here, here, but I don't see stratification. I don't see tufting. And I'm happy to attach. Actually, let me see if I can find it right now. Should be. I'm just.
I agree that this is one of the hard areas of ovarian pathology is this boundary between borderline and benign cystadenoma. I talked to our residents about finding epithelial atypia, and I think usually in those cases where you have any degree of nuclear enlargement and so forth, that's a very helpful criteria.
Yeah, I agree. I would say the same thing. Usually I want to see some degree of cytologic atypia. I kind of relate it to, I want to see what it would look like if we're talking the GI tract, like a tubular adenoma, those type of nuclear enlargement and pseudostratification. So, but it's definitely a tricky area.
So I just went on my WHO Blue Book online offering, and this is a picture under the topic of mucinous. I can't move. So anyway, we'll look at the picture and then I'll here, this is multiple small cysts, and this is basically called a mucinous cystadenoma. All of these are pictures of mucinous cystadenoma, which I would say that 5 or 7 years ago, I might have also classified as borderline mucinous tumor. They're composed of multiple cysts and glands by simple non-stratified mucinous epithelium. There's absent or minimal mitotic activity, cellular luteinization, which our case is showing. I think this case was a little bit easier to sign out as a mucinous cystadenoma because actually the area that I showed you was a 1 centimeter nodule in what was a 15 centimeter tumor. So it was also easier to call it as a mucinous cystadenoma because it didn't meet that 10% cutoff for the proliferation component. But I think that this is a difficult case because I can tell you for sure that 5 years ago, 7 years ago, I would have called this lesion, no questions asked, borderline, just because of the fact that it has, and I'm using this term somewhat loosely, microcystic architecture. There are a lot of small cysts, and that was enough in the old days to call it mucinous cystadenoma. Borderline mucinous tumors. But I think in today's world, this would be called a mucinous cystadenoma, or, some people like to say mucinous cystadenoma with focal proliferation. The clinical behavior is identical. It's virtually 100% 5-year survival. So I just wanted to share this case. The next case that I have is along the same lines where you've got, most of it looks like a usual old mucinous cystadenoma, nothing of concern. But then you go to this other section where it's getting a little bit, I guess, juicy is the word that we often use. Foveolar type epithelium, the nuclei a little bit more round, little bit more rounded. Let me see. There even seems to be a mitotic figure here. And there is at least one area. So here you can see the, one of the invaginations of the mucinous gland. It has this sort of reactive stroma around it. and also a couple of like a giant cell over here and inflammatory cells surrounding it. So any thoughts on how you would qualify this tumor?
Um, if there are
Percentage
no,
of, sorry,
I'm sorry?
what percentage of this lesion with gastric mucosal dysplasia, metaplasia has covered?
So that's,
Percentage of the total surface.
yeah, it was less than 10%.
Mm.
So again, this is another case that I think that 5 or 7 or 10 years ago, I would have raised the possibility of a borderline tumor, but in today's world, I don't think, irrespective of the percentage of the population, I don't think the epithelial proliferation is enough. What I find very difficult with mucinous tumors is the issue of cytologic atypia. My own observation is that mucinous tumors show much more variability in the degree of atypia, the nuclear and cytologic differences from site to site. So it's very common to see a tumor that is an admixture, it's a gastrointestinal type differentiation, and it has a mix of both foveolar type epithelium and intestinal type epithelium. And naturally, the cytologic characteristics of those two different sites are different. And so how do you know that it is atypia versus metaplasia? And I don't know that I know what the answer to that question is, but I mean, this is the type of case that we always almost always show at least one other person. Luckily, the volume component of this lesion is low, so it's easier to call it cystadenoma or to call it cystadenoma with focal proliferative activity. But my own feeling is that in today's world, even if the entire tumor looked like this, it's probably still, I would still call it a mucinous cystadenoma, acknowledging that other people might not. I have been involved in a very large inter-observer variability study on difficult mucinous tumors, and there were over 100 cases. And I have to say, our inter-observer variability for the two extremes is very good, but for the middle areas, it's moderate. So, those are the criteria. You have to be aware that this is an area of significant diagnostic variability.
may I ask a question?
Yes, please.
Yeah, the area which you showed us, that's a kind of invagination with reactive process. How can we differentiate it from desmoplastic stromal reaction? I mean, that's a very ambiguous case. One thing, we have atypia. The second thing, we have kind of invasion appearing lesion with reaction. So how can we be sure that it's not invasion? In the
How can you
of
be sure that it's not invasion? Is that
how
what
can
your
we
question?
differentiate it from? Yeah. What if it's a desmoplastic stromal reaction?
Right. So I think I have a couple of other cases. So I think in our world, it would be a little bit easier to answer because I would probably do a keratin stain on this. And if there were no single cells around it, I would assume that this is an invagination and mucinous granuloma. The other thing is that because it's less than 5 millimeters, then it would be microinvasion in a borderline tumor, which has clinical significance wise is there's no difference between mucinous borderline tumor and mucinous borderline tumor with microinvasion. I don't feel that this, I mean, it's a little bit of a judgment call. It's not projecting very well on this screen, but this is actually over here a multinucleate giant cell, which also suggests to me that this is a mucin granuloma as opposed to desmoplastic reaction. Desmoplastic reaction tends to be less inflammatory. This is a little too much inflammation. I don't know if anybody has anything more to ask. I think I have another piece. I mean, it's very common to see these areas. So here's another area. You're not seeing the gland in here, but you've got hemosiderin-laden macrophages, edema, inflammatory cells. So if this is the reaction that I see, then I'm going to call it mucin granuloma rather than see here also you're seeing a similar sort of edematous stroma with foreign body with hemosiderin-laden macrophages. I agree that sometimes it's really difficult to tell. The other thing is that the invasive component, if you think that an area is invasive, it should be carcinoma. You know, you need to have something that you can call cytologically carcinoma. If I can't call it cytologically carcinoma, then by definition, it's not invasive. Does that make sense?
Yes.
Okay, so now in moving to increasingly complex cases. So this, I think, is sort of straightforward and easy in the sense that this is very highly complex with, you know, cribriforming and labyrinthine arrangement of glands and just very, very complex. Here's a nice area of cribriforming. Cribriforming is difficult because sometimes I think this is true cribriforming where the cells are orienting differently, but sometimes if there's a lot of complexity to the architecture, it's difficult to determine whether it's just whether it's true cribriforming or not. But I think everybody would agree that this is, you really don't even need to go to higher magnification to call this as a mucinous carcinoma. Okay, so this is what I meant with a complexity versus cribriforming. This is not something that I would call cribriforming, in part because it's all it just doesn't have, again, I think sort of an area that where I don't know whether pathologists are agreed about it or not, but the epithelium does not look carcinomatous to me. And so therefore, to me, this is architectural complexity rather than true cribriforming. You can see it's an artifact of the cells sort of proliferating and piling up as opposed to true fibriforming, which is a pattern of growth. So this area I would not call, if this was the only thing present, I would not call carcinoma. But to your point, invasion is very difficult to assess. So hopefully you can see in this area. So you can see here's, you know, the epithelium is atypical here. You've got, sorry, my field under the microscope is much more broader. So you've got nuclei with nucleoli, you've got a couple of mitotic figures, you've got some apoptosis going on. So this, I think, is atypical epithelium. And on lower power, you can see that it has reaction around it. And it doesn't look very different from the previous case where I was telling you that it was a mucin granuloma. I just think that it's difficult, and I don't know that we have a good answer to the question. And here also you can see these multinucleate giant cells in here that, you know, are more inflammatory. What's the word? Osteoclastic sort of giant cells in here forming what I guess in the older literature we would refer to as an epulous type of inflammatory response. But we also did a keratin stain on this. Sorry, keratin stain. Here's our keratin stain. And you can see that some of those things are, there's single cell keratin positive cells in the stroma. But also this is the CD68. And here's the same focus, and you can see that, you know, some of the multinucleate giant cells are macrophages rather than tumor cells. So it's a mixture of both tumor cells and inflammatory cells, which can happen. So we did call this a focus of invasion. It's less than 5 millimeters in any one dimension. So this was called micro invasion. So in mucinous tumors, here's, you know, an even larger area with this epulous type response with this osteoclastic giant cells, loose edematous inflammation. So now for mucinous tumors, there is a difference. There are two microinvasive terms that are used with mucinous tumors. One is borderline tumor with microinvasion, which is when you see a less than 5 millimeter focus with sort of microinvasive pattern that is similar to what you would have seen, you know, similar to the microinvasion that we see in serous tumors. So single cells or small clusters of cells sitting in empty spaces and with low level of cytologic atypia, the same level of cytologic atypia as in the borderline tumor, or at least within range. There's never the same amount, but not high level cytologic atypia. But you can get a different type of microinvasion, which you would label microinvasive carcinoma, if the invasive component is small, 5 millimeters, but there is high-grade cytologic atypia, that is actually microinvasive carcinoma arising in a borderline ovarian tumor. I don't think I have an example of that entity. Let's see. Okay. So anybody want to comment on, so technically speaking, this type of a pattern would be micro invasion if it wasn't so cytologically atypical. This is if this was micro, you can see that it's not micro. This would be micro-invasive carcinoma. So people's thoughts on this case? So it looks like there's a component that is quote unquote low grade or, you know, borderline-ish looking. But then there are these nodules of invasive tumor here. And you've got marked atypia of the overlying epithelium. So any thoughts about this one? Sorry, is that in focus? I'm happy to see that a lot more people have joined. You were not on when I first looked around, so please feel free to jump in and comment on what you think. You know, you don't have to make the diagnosis, differential diagnoses. What should we be thinking about?
Could this lesion follow the spectrum of neoplastic transformation from borderline to low-grade mucinous carcinoma?
You're right.
Mucinous
So one possibility is that this is carcinoma arising in a borderline tumor. And if there is enough carcinoma, then we wouldn't even think, you know, you wouldn't even mention the borderline tumor, just because once the carcinoma exceeds a certain amount, whether it arose in a borderline tumor or not is difficult to assess, because mucinous tumors show quite a bit of variability in their sort of cytology from area to area. So one, you're right, that is, if this was a small focus, then we would call it micro-invasive carcinoma arising in a borderline tumor. Is there any other consideration? So are we all agreed that there is some amount of carcinoma in this slide?
Yes.
Yes. So we're agreed that there is carcinoma here. So how would you describe the pattern of the tumor, of the invasive component?
It looks out of a microinvasive.
Right. So it's infiltrative, invasive, and I agree with you that this almost has a microinvasive look to it. So when you see infiltrative mucinous carcinoma, what should you always think about as an exclusion diagnosis before you call it primary ovarian mucinous carcinoma?
Is it infiltrative or pushing type?
Exactly. So I think this is an infiltrative pattern because you've got single glands infiltrating into the stroma with a desmoplastic reaction to it. And then you have this other nodule. Let me see the first one we were looking at here. You've got these glands that are what we would call sort of pinched off glands with these, you know, here you've got this sort of sharp area. Here's a gland that is sort of funny shaped and pinched off. And so this would be an infiltrative pattern of growth. So what is always something that one must think about when one sees a mucinous tumor in the ovary with an infiltrative pattern of growth?
Possibility of metastatic secondary.
Yeah, you're absolutely right. I'm sorry, I couldn't hear. Aisha, did you say something also?
Yeah, metastatic lesion secondary.
Right. So in this case, whenever you see infiltrative infiltrative pattern in an ovarian mucinous tumor, you must consider the possibility of a metastatic ovarian carcinoma. And one of the issues with respect to mucinous tumors of the ovary is that there has been a paradigmatic shift in our thought process. So if you look at the older literature, there are a lot of cases of infiltrative pattern mucinous carcinoma. But in today's world, the number of infiltrative pattern mucinous adenocarcinomas that are primary in the ovary is very, very small. And so because of those relative ratios, it's incumbent on us to.
ሶልዬ
Yeah.
ማርዬ እንዴት ነሽ? ቪዲዮ ኮንፈረንስ ላይ ነው ኋላ ልደውል።
Okay, so that's just background. Sorry. So you have to think about metastatic carcinoma. So the which are the metastatic carcinomas that one must think about? Which sites would you think about?
GIT, gastrointestinal.
Yeah, so gastrointestinal, and within the gastrointestinal part, colonic adenocarcinoma typically gives you sort of the dirty necrosis, and I think is a little bit easier. But the other two sites or three sites that you have to think about is stomach, pancreas, and endocervical type gastric carcinoma. Those three also metastasize to the ovary, and there are documented cases where the ovarian mass is the presenting tumor. In fact, for colon carcinomas that metastasize to the ovary, especially in young patients, I don't know why, but they tend to more commonly present with the ovary or rather, a higher percentage of metastatic ovarian involvement presenting as the primary tumor happens in young patients in their 40s. And I don't know whether that's a selection bias or for some other reason. So in our world, if I had this appearance, actually for this case, I would do a complete chart review to make sure that the patient doesn't have a prior known history of a gastric or a pancreatic tumor. I would review the imaging studies to make sure that the patient doesn't have a gastric or a pancreatic mass. And even then, I would sign this out as a mucinous tumor with an infiltrative pattern of growth and a disclaimer comment that would be that, absent I would say something to the effect of, mucinous tumor with an infiltrative pattern of growth. This may be primary, this may be metastatic, and this can be classified as primary ovarian if the possibility of a gastric or pancreatic carcinoma has been excluded. And the reason that I say gastric or pancreatic is because with colon, you can do the stains and it should be diffusely and strongly CK20, CDX2, SATV2 positive. But pancreatic and gastric type tumors can also be CK7 positive, just like primary ovarian mucinous tumors can be. So that's not a distinction that is easy to make based purely on histology. And so we always ask the clinicians to exclude the likelihood of a pancreatic or a gastric type carcinoma. The one good thing, and Ekene, you probably know this more because the data comes from your previous primary institution, MD Anderson, the response of gastrointestinal type ovarian tumors is pretty good to gastrointestinal type chemotherapy. And so so if we're not sure that this is a primary ovarian tumor, then at our tumor board, the discussion would be that the patient should be given gastrointestinal type chemotherapy, which is FOLFOX or FOLFIRI, rather than giving them the ovarian mucinous carcinoma therapy, which is carbotaxol. So just sort of background information on how it would affect management here. I don't know, I guess I'm not sure what you would do in the setting of limited choices. Maybe it doesn't have implications. Okay. So, go. So you can see the pattern of this tumor, which I think is more reminiscent of a borderline serous tumor, right? This pattern can also be seen with mucinous lesions, and here is an area with mucinous type area. So I guess how would we label this? Tumor.
Does this have a mixture of epithelium?
Yes, yes, there is. There is a mixture of, here's a nice area maybe that you can see both types of epithelium. So you've got mucinous epithelium here and non-mucinous epithelium here.
Mullerian type.
I'm sorry?
Mullerian type.
Mullerian type, yes, correct.
Is it seromucinous borderline tumor?
Right. So I think that this would be called a seromucinous borderline tumor. And I want to, so these are going to be CK7 positive. They're also going to be hormone receptor positive, unlike the colonic type, which are typically not strongly ER positive. But again, throwing out a caveat out there, ER, and maybe Lewis actually probably knows more about this than I do. ER in our world has transformed. So originally ER was used for two reasons. One, it was used for prognosis. For instance, in breast carcinoma, if you have a hormone receptor positive carcinoma, the outcome and treatment is different. And then we were also using it as a diagnostic marker, which is, well, you know, if you've got two tumors, you've got an adenocarcinoma, the adenocarcinoma is ER positive, and we would say, oh, that favors a breast or GYN primary. But in today's world, the importance of ER as a prognostic marker has increased enormously. And so its use as a diagnostic marker has dropped very significantly because we've improved the sensitivity of ER in today's world is so high that, you know, you can easily get colonic carcinomas that'll show low-grade staining. You know, 30 to 40% of lung adenocarcinomas will show ER staining in our hands. So we no longer use ER as a diagnostic marker to favor one or the other category. But in this setting, this is a seromucinous tumor. This was virtually 100% 3+ positive. So one other point I want to make here, and then we'll stop, is that within the category of ovarian tumors, 2020 or 2019 WHO got rid of seromucinous carcinoma. So if there was carcinoma in here, it would not be called seromucinous carcinoma. And I think this is a little bit convoluted. So if it's borderline, it's its own entity, as in seromucinous borderline tumor. But if it's carcinoma, it is actually an endometrioid carcinoma with mucinous differentiation. The label of mucinous carcinoma in the ovary applies now only to tumors showing gastrointestinal type mucinous differentiation. So I just gonna take you back. Here we go. I thought I'd marked it, but I haven't. So I will send you a screenshot of the definition of mucinous sort of tumors in the ovary. And the reason that seromucinous carcinoma is now lumped with endometrioid carcinoma is based on both molecular and clinical outcomes. So seromucinous tumors show the same molecular profile as endometrioid carcinomas of the ovary and also behave in that way. And so that's why the sort of category of seromucinous carcinomas was removed. One other thing I want to throw out there is that there's a couple of small series of clear cell carcinoma arising in seromucinous tumors. So seromucinous tumors often show an admixture of, as you said, all Mullerian type epithelium. So mucinous, serous, clear cell, and also sometimes squamous. So just to be aware of that. And with that, I'm going to stop sharing my screen. And we're up on time. I had another tray, but I don't remember exactly why I had another tray, so we'll stop right here. All right. Abby will be in touch with you all to see if next week works for our project meeting. And I would like to suggest that we set that up as a pattern, which is the third Wednesday of the month, we're meeting as part of our sort of fellowship group. And then on the fourth Wednesday of the month, we meet as a project group. I honestly think that this project has the potential to really make an impact, because if you've take a look at the NCCN Africa guidelines. I would love to hear what you have to say, because there are things in there that, in my opinion, now having worked with you guys, I feel cannot be implemented, not in the current world, in at least some of your places. And so it'd be really important to have that feedback. We shouldn't be making the guidelines for other places. You guys have to take primary leadership in that role. We're happy to share our experiences, and especially our experiences where we've made mistakes. You shouldn't have to make the mistakes that we have made and learned from, but the leadership should come from you guys. So hopefully we can meet next week, same time. Otherwise, we'll find another time that works for everybody. You should all have access to the folders for the project, so please take a look. Just glance through everything and familiarize yourself with what is in there. And with that, I will say farewell.
Sorry, doctor, before we close.
Yes.
Just a few minutes before the meeting, we were discussing with Dr. Aisha about the timetable.
Yes,
In ours, it is 1 p.m.
okay,
and this time is just in between the beginning of the night and the time that we come to our home. Sometimes we hear this platform while we're driving, because the time is not as such, which this specifically this 1 p.m. Can we make it a bit
7 p.m. actually.
forward,
7 p.m.
1 hour forward?
um,
Aisha, what did you say?
I certainly
7
don't
p.m.
have a problem with that, but maybe I'll defer to Lewis on this one, and maybe Abby can send out a sort of reach out to everybody so that we can reset the time to whatever works for everybody. Yeah. So this
Yeah,
is
we want you to be able to attend, and I think the challenge, we had some people coming from the West Coast of the United States, so we would be starting at a little earlier for them. But if it's better, more convenient for you, you're the ones who need to be here, so we want to make it a value for you. So let us revisit that and make the announcement.
definitely. All right. All right, guys. Have a good week.
Thank you, everyone.
Thank you.
Thank
Thank you
you.
So much.